Now coming to hemostasis. What is hemostasis? Suppose we have an injury, the blood clot is formed and it stops the bleeding. This is called as hemostasis. This can be done surgically also. If it is a bigger wound, that is also called hemostasis. But we will be discussing the physiological hemostasis that is happening in the body. So what happens whenever there is an injury? There usually happens three processes. The first one is vasoconstriction. Vasoconstriction. An injury is happened and my blood vessel is oozing out and it is bleeding. So what it can do, if there is a vasoconstriction, it will try to prevent the blood loss. So this vasoconstriction is the first event that is happening. Then second one is primary platelet plug formation. Primary platelet plug formation. And third event that is happening is primary is there, then there should be something called as secondary platelet plug formation. So all these three events happen during the injury. So what happens in cases of vasoconstriction? How vasoconstriction is happening? The vasoconstriction happens because of local reflexes only. And some of the pain fibers are also getting stimulated and they also cause the vasoconstriction. And another thing that happens during vasoconstriction, it is done with the help of thromboxane A2. What is this thromboxane A2? This thromboxane A2 is a powerful vasoconstrictor. It is a vasoconstrictor and it is released from the platelets. They also will cause the vasoconstriction. Then second event that happens is primary platelet plug formation. The platelets come together in the place of injury and they will plug it. So this stops the bleeding. So this platelet plug formation is the second event. Then if the bleeding is not stopped, usually for minor bleeds, if for minor bleeds, only primary platelet plug formation is sufficient. But the bleed is major. There is a big injury and there is a huge amount of blood oozing out. Then there is a requirement for secondary platelet plug formation. Then it is done with the help of clotting factors as well as the platelets. Both of them are very essential. But the most important factor is clotting factors, because with minimal platelets also this platelet plug formation, secondary platelet plug formation can happen. This is also called as clotting mechanisms. So coming to the platelet plug formation. So platelet is the predominant player here, and especially if the bleed is very minor, the platelet is sufficient to stop the bleed. That's why platelet is required for determining the bleeding time. Whenever we do the experiment, we do two things. One is the bleeding time and the clotting time. In bleeding time, whenever the injury is minor, just the platelets will come and stop the bleeding. This is called as the bleeding time. But the formation of fibrin thread happens once the clotting factors are activated. That is called as the clotting time. So for minor injuries, platelet is sufficient, as I said, and it is a determinant for bleeding time. So platelet has three properties, how it stops the bleeding. First thing is there is platelet adhesion. The platelet gets attached. The platelet is coming and getting attached to the vessel. So that is called as platelet adhesion. Second thing is platelet activation. Platelet is getting activated. And finally, the third part, which is the platelet aggregation. So all this process happens and all of them are self-explanatory. First, addition. Addition means the platelet is coming and getting attached. It gets attached with one factor. That factor is called as von Willebrand factor. Von Willebrand factor. These platelets have one receptor which is called as GP1 bar 9. This GP1 bar 9 is the one which is getting addition to the von Willebrand factor. So this factor we have to remember. It is 19, GP19. So this GP19, whenever it is absent, what will happen? The platelets will be big in size. But their functionality, it looks big, but their functionality is very, very low. The functionality is low. So what will happen? This will produce some disorder because of the functionality defect. And what is the name of the disorder? When GP19 is affected or the platelet addition is affected, that disease is called as Bernard-Solier syndrome. Bernard-Solier syndrome. And here we have a clue also. This big platelets is responsible for Bernard-Solier syndrome. And for the big platelets, the 19 factor is very, very important. Second comes the platelet activation. In platelet activation, what happens is there is change in shape of the platelets. Now the platelets, what it will do is, it will send its pseudopodia, like the actin myosin contraction will happen, and they will try to form a mesh and stop the bleeding. So the platelet shape changes, then thromboxane A2 is released. Thromboxane A2 is a vasoconstrictor and it prevents a further bleed. So the contractile units which is present inside the platelets are like the muscle, the actin and myosin is present. So they will form the pseudopods and then they will stop the bleeding. Then coming to the final process, that is aggregation. What is platelet aggregation? Platelet is trying to recruit more and more platelets to the particular site. So that is called as aggregation. It happens with the help of a receptor. That receptor is called GP2B3A. We have to remember, first one is already taken. GP1 goes for the Bernard-Collier syndrome. Now GP2A of two different platelets. One side 2B3A is there. Another platelet also has the 2B3A. Both this 2B3A, what will happen is they will come and get attached and they will cause platelet aggregation. If this aggregation is defective, it leads to one another disease. That also we should remember, which is called as Glanzmann thrombasthenia. Thrombasthenia. Asthenia, what is the mean? Throm means thrombocytes. Thrombocytes is the other name for platelets. Asthenia means it is the weakness. Now platelets are there. In both Bernard-Collier as well as in Glanzmann thrombasthenia, platelet number is completely normal, but their functionality is reduced. One addition is reduced, another one aggregation is reduced. So again, if the addition and aggregation are not functional properly, what will happen? It will end up with bleeding disorders. Usually what happens in platelet defect? It is presented, so they will give you a history. First you should identify whether it is a platelet disorder, whether it is a bleeding disorder or a clotting disorder, because the reason for bleeding disorder is primarily a platelet defect, whereas the clotting disorder, it is due to the clotting factor deficiencies. So first thing is you should analyze the clues in the history itself. What will be the clues for a bleeding disorder? In a bleeding disorder, we said that it is required for stopping the minor bleeds. So the minor bleed will be the clue. If the history says the patient is having minor bleeding disorder or minor bleeds like history of bleeding gums, purpura and small red spots, then that is more in favor of a bleeding disorder. And the bleeding time will be prolonged. When you do a BT, the BT time will be prolonged. BT is increased. So what could be the reasons? The reasons could be platelet count can be less or it can be functionally deficient. If the platelet count is less, what is the defect called as? It is called as thrombocytopenic purpura. And the most common reason is unknown. That's why it's called idiopathic thrombocytopenic purpura. Here mostly the reason said is there are antibodies against the platelets. So this is ITP. This ITP is nothing but idiopathic thrombocytopenic purpura. Then the count is normal. There should be functional defect. So if the count is normal, then it can be an adhesive defect. Whenever it is an adhesive defect, what will happen? The platelets will be big and they are called as Bernard-Collier syndrome. Whenever there is an aggregation defect, it is called as Glanzmann thrombasthenia. So this is the entire mechanism for the primary hemostatic plug. Now coming to the secondary plug formation. Now secondary plug means it is nothing but a clotting mechanism. The clotting mechanism is of two types. One is the intrinsic pathway, another one is the extrinsic pathway. We have to remember this entire pathway because multiple questions are asked. Intrinsic pathway, then another pathway is extrinsic pathway. So what happens here is whether it is an intrinsic pathway or an extrinsic pathway, both of them will finally form one activator. That activator is called as prothrombin activator. That activator is called as prothrombin activator. What is intrinsic pathway? Intrinsic pathway means there is some defect in the blood itself. The blood itself is having some trauma. Whenever the blood is injured, then or any defect in the blood itself, then intrinsic pathway will get activated. Or whenever it comes in contact with a collagen. Suppose you are doing an experiment and you are filling that capillary tube. That is a type of intrinsic factor activation because whenever the blood touches a capillary tube, which is collagen, what will happen? It will activate the intrinsic pathway. So either a blood trauma or a contact with a test tube, both of them can activate the intrinsic factor. Then what is extrinsic factor? The blood is here in the vessel and the tissue is there. Suppose there is an injury and the blood is entering here. So the tissue will produce some factors which can activate this pathway and stop the bleeding. That is called as extrinsic pathway because it is happening outside. It is depending on the factors that is outside the blood. That is the tissue. But whether it is intrinsic, whether it is extrinsic, the final product formed is a prothrombin activator. What is this prothrombin? Once the prothrombin activator is activated, then nobody is there to stop the reaction. The reaction, next reactions will be like it will be like a dominoes. It will happen on its own. And this is the example of a positive feedback mechanism. Positive feedback mechanism, because one factor stimulates the other, which stimulates the next one, and this keeps on happening. It is a vicious cycle. So thrombus formation is a positive feedback mechanism. This was asked in recent NEET also. Thrombus formation is a positive feedback mechanism. So once the prothrombin activator is formed, what it will do? It will activate the prothrombin. Prothrombin will be converted to the thrombin in the presence of an important substance, that is calcium. The calcium requirement is very minimal for this activation. So hypocalcemia will not cause any problem to the clotting mechanism because the quantity required is very minimal. If the hypocalcemia becomes very severe, the patient will go and die of laryngospasm, but still the clotting mechanism will happen. Why? Because the requirement is very less. So prothrombin is converted to thrombin. This thrombin will convert the fibrinogen to fibrin monomer. Again, in the presence of calcium, fibrin fibers will form, and there comes finally one factor which is called as clot stabilizing factor. It stabilizes the clot. Otherwise, what will happen? The clot will get dislodged and it can move, and again bleeding will happen. So once the clot stabilizing factor comes into play, they form cross-linked fibrin fibers. More and more cross-linked fibers are formed. They will be very taut and stiff. So that is the reason the clot is always very strong. So now we have to discuss the entire pathway of intrinsic pathway and extrinsic pathway. And we should discuss about the particular test that can be done also. So intrinsic pathway, we told you it starts whenever there is a blood trauma. There are several clotting factors, like 13 to 15 of them. In that, the clotting factor number 12. Don't try to remember with the Roman numerals. It will be very difficult for us to remember. Just remember with the simple numbers. So let's start writing it. Factor 12 will get converted to 12A. Then what happens? This 12A can activate factor 11. 12 next is 11. 11 will get activated to 11A. Then it happens in the presence of calcium. This also happens in the presence of calcium. Then this 11A, what it can do is it can get converted to, it activates the factor 9. Here 10 is missing. 10 will come a little late. Then 9 will get converted to 9A. So 9A is activated. And there is one more factor which is responsible for activating the 10th factor. 10 is the most important and dominant factor which gets converted to 10A. It is one of the most important and dominant factor. Now for activating 10, we need two factors. That is 9A should be activated and 8A should be activated. So 12, 11, 9 and 8. And finally 10 will come. So 10 will get converted to activated to 10A in the presence of calcium and phospholipids. So these two has to be present, and usually their requirement is very minimal, and platelets also should be present. So all this, now what they will do is this 10A is the final step which will convert into a prothrombin activator. This 10A can get converted into prothrombin activator in the presence of factor 5 and calcium. So finally we land up with prothrombin activator. Whether it is intrinsic factor or an extrinsic pathway, ultimately we will land up with prothrombin activator only. Now let's talk about the extrinsic pathway. Extrinsic pathway, I told you, when the blood reaches the tissue, it will produce some substance and form the extrinsic pathway. So it is a tissue trauma. So what is the factor getting activated? The factor is 3. Factor 3 is also called as tissue factor because it is released from the tissues only. Then this 3 factor, it is a short pathway, it's very easy to remember. This 3 will activate, ultimate factor is 10. So what number I should add to bring it to 10? 3 plus 7. So 7 gets activated to 7A. So 3 plus 7 just becomes 10. Just remember the intrinsic pathway, extrinsic is very simple. So 7 gets activated to 7A. 7A can convert 10 to 10A. And 10A in the presence of 5 and calcium, this is the same pathway. There is no change here. Here we have to remember only two factors. 3 plus 7 is equal to 10. Whereas this side we have to remember 12, 11, 9, 8 and 10. So this is the entire pathway. Now coming to the test for this pathway. So the longer the pathway, Just remember longer the name. So this intrinsic pathway is tested with the help of a test called as PTT. What is this PTT? It is nothing but the partial thromboplastin time. The shorter the pathway, the shorter is the name. Extrinsic pathway is represented with PT. What is this PT? It is prothrombin time. It is prothrombin time. So once we do the test, if PTT is coming abnormal, then we should look for the intrinsic pathway factor defects. Then there is, after the prothrombin is activated, what is this pathway? This is called as common pathway. This pathway is common for both of them. So this is called as common pathway. And what is the test that is used to do the common pathway? That is thrombin time. So thrombin time is the one which is used to detect the common pathway. For the intrinsic pathway, it is PTT. Extrinsic pathway, it is PT. Then for the common pathway, it is TT. That is the thrombin time. And this clotting mechanism is used to stop minor bleed or major bleed. It is for the major bleeds. So if there is a clotting factor deficient, what will be the history? The history will be classically having a very huge amount of blood loss. Major bleeds will be there inside the body, especially because there is no external injury. Whenever the person is going and getting hit in somewhere, what will happen? There will be a severe internal bleed, because normally also there are some bleeds happening which are plugged by the platelets. But in this person, the clotting factor is deficient. So a little major injury will damage the vessel there, and more blood loss will be there. Internal blood losses will be there. So what will be the history? We saw the history for platelet defect. There will be history of minor bleed like bleeding gums, purpura, something like that. But here there will be large bleeds. And they will give a classical history. Usually this clotting disorder, the major one, that is hemophilia A, that is dependent upon the factor 8, is a X-linked disorder. So they will give a classical history of a male young child who was running or walking around and suddenly fell on his knee and developed a huge hemarthrosis or a huge swelling around his knee joint. That will be the classical history. The hemarthrosis will be the classical history. And they will ask which is the most common clotting factor defect. The most common clotting factor defect is factor 8. So the factor 8 deficiency is the most common among these three, and this will cause hemophilia A. And factor 9 deficiency, which is also called as hemophilia B, it will cause hemophilia B disorder. And factor 11 deficiency will cause another form of hemophilia, that is hemophilia C. So these are the most three important. Among them, the factor 8 is the most important cause. And factor 8 is involved in which pathway? Usually the PTT is prolonged in those persons because factor 8 is involved in the clotting mechanisms of the intrinsic pathway. Now coming to a different disease. One disease, there will be a history. This has been asked in MLE questions, but it can be asked in a further NEET questions also. What happens is they gave a history of a child who was playing and he has got an injury. Following the injury, the bleeding stopped. But after that, what happened is there was again a bleeding. Then they will give you the test results. The test results like DT, clotting time, PTT, PT and TT. All of them were normal. What is the defect? So this disease we have not studied anywhere, and it is very rare to find this disease. I call this disease as a ghost disease. Why? Because all the tests are normal. All the tests that we normally do in the laboratory is coming out to be normal. So what could be the defect? Here the clot is being formed. That this clue gives us the clot is being formed, but it is bleeding ahead. When you go back and refer the video, you can see that at one point I told you the fibrin monomer should be stabilized to form a fibrin, final fibrin threads. If it is not stabilized, what will happen? They will dislodge. I told you the clot will get dislodged. So the clot is getting dislodged here and bleeding is happening. So what is the factor deficient here? It is called as clot stabilizing factor. Is there any number for this factor? I told you what is this disease. This is a ghost disease. What is the ghost number? The ghost number is nothing but number 13. So this factor number 13 was the answer for the question. So this factor 13 is the one which is deficient in case of all tests, all normal tests that ever whenever we do a clot stabilization test, it will be abnormal. But routinely we don't do this test. Routinely we do BT, CT, PT, TT as well as PT. So all this tests came out to be normal, but still the child was bleeding again and again after the stoppage. So it is the factor 13 deficiency which is causing this demerit. Thank you. This brings us to the end of blood physiology.